Well, welcome everybody to the GHP Brown Bag Seminar. We're always delighted to welcome our guests, but we're especially delighted because we're welcoming back John Quattrochi. He did his doctoral degree in our department, and so it's a pleasure to have him back. John is currently associate teaching professor at Georgetown University, where he also directs their Master in Science program on global health. And he has a wide range of research interests and research topics. And much of his research, as you'll see today, focuses on the Democratic Republic of Congo, where he has worked on vouchers, humanitarian issues, and a number of other pressing development issues, including water and sanitation. And this is also something that we've collaborated on this project. And I just looked in my folder, my project folder, and our first meetings on this project were in 2016. So it's really, it's good to see it finally come to fruition. So let me hand you the floor, John. Welcome again.
Thanks, Kevin. Yeah, I guess that's a lesson for any graduate students that perseverance is a very necessary trait in this line of work. Let me share this. Okay, how does that look?
Good.
Looks good.
Wonderful. So it's wonderful to be back here. Thank you again for the invitation. Any shortcomings that I demonstrate today are not the fault of my training in GHP. I'm going to try to present about 30 minutes of material. I'm very happy to be interrupted as we go if questions come up, whether you just take yourself off mute or you put something in the chat. I'd love for this to be as much of a discussion as possible. Let me just, it's always a question of where to put all these Zoom buttons. There we go. Okay. All right. So yeah, what I'm going to present on today are the results of this cluster randomized control trial in DRC that looks at the National Rural Water and Sanitation Program to see if it had effects on diarrhea and growth faltering. And this is joint work with Kevin, as well as Eric Mbukiehe at Duke, and Aidan Colville, Caleb Dohu, Yannick Lokaya, and Luca Staniskiv at the World Bank. Okay, so if we look around the world at access to drinking water, sanitation, and hygiene, we are not going to reach the Sustainable Development Goals of universal access by 2030. And what this figure shows is progress from 2015 to 2020, and then how much that progress would need to accelerate to reach the SDG WASH targets. And you can see we're doing okay, we're doing well on open defecation, but on these other measures, we need to accelerate by 2 to 4-fold our progress. And if we look at Africa specifically, the challenges are even greater, where we would need to accelerate by 4 to 42-fold what the increases in access from 2015 to 2020. And this inadequate access has severe consequences. There are over 800,000 deaths each year attributable to diarrheal disease due to inadequate WASH. There's widespread linear growth failure or stunting, where children are not reaching their biological potential, and that's linked to long-term harms to cognitive development. There's a high time burden of water collection that falls disproportionately on women and girls. And all of these problems are most severe in rural areas of low and middle income countries. The good news, in a sense, is that we have a lot of tools at our disposal. There are many possible WASH interventions. The design space is vast. We can think about demand-side interventions like behavior change, communication campaigns, pricing reforms, legal reform. On the supply side, we can provide hardware like latrines, boreholes, filters, or experiment with privatizing or nationalizing service delivery. And then there are approaches that combine demand and supply side, like decentralization. This program that I'm going to talk about today combines behavior change communication, direct hardware provision, mostly of protected springs, and cement slabs to improve latrines, and village level water committees. the challenge of having a design space that's so vast is that it requires many studies to amass the evidence to prioritize different interventions in different contexts. So even though we've been studying water and sanitation for a long time, we still don't have a really good sense of what the most cost-effective options are in different contexts. So in the Congolese context, water and sanitation are a huge challenge. About 52% of Congolese have access to an improved water source. About 29% use an improved sanitation facility. So in response to that, the government, in collaboration with UNICEF, launched a program called Healthy Villages and Healthy Schools in 2008. This is a joint effort of the Ministry of Public Health and the Ministry of Education. It's organized by UNICEF, implemented in part by UNICEF, but more so by a number of NGOs that are subcontracted. It was financed by the British at a level of about $30 million per year. And by the time we became involved in 2016, 2017, it had reached about 6.5 million people across thousands of Congolese villages. And the map on the right is a map of Congo, where the gray areas are health zones where this program was active. To say a little bit more about how the program works, there are these 9 steps. It begins with a decision by a village and the health authorities to start the program, and the village commits to seeing through the entire community-led process. The step 2, the health authority does an initial assessment of WASH challenges. Step 3, over several days, the community and the health authority work together to assess what could be done or what the main challenges are. Step 4, there's some training of members of the village in both maintenance of water and sanitation facilities, but also conflict management and cash management. And after that, a WASH committee is elected. In step 5, there's, again, a several-day process where the community plans out what the interventions will look like specifically. Step 6 is where these NGOs come in and build or improve water infrastructure, sanitation infrastructure. And then 7 and 8 involve some follow-up by the health authority, where in step 8, if the village has met the 7 norms, then it is certified as a healthy village. So here's a picture of one of these community meetings talking about what some of the main challenges are around WASH and what can be done. This is a WASH committee who we met in the village of Demba. On your left, you can see a picture of an unprotected spring. That's the most common water source in the areas where this study took place. And on the right, a protected spring of the sort that this program often provided. On the left, a basic pit latrine, and on the right, an improved pit latrine where there's a concrete slab and a concrete covering of the latrine. Maybe I should say altogether, the program spent about $7,000 per village, about $2,000 on sanitation infrastructure, $2,000 on water infrastructure, and $3,000 on personnel costs. So looking at the timeline, Kevin mentioned we started exchanging emails about this in 2016 or so. We held a impact evaluation workshop in 2018 in Kinshasa. Randomization occurred in June of 2018, so we don't have any baseline data here. Our first data collection was in October, December 2019, the midline survey. I will refer to that as the 5-month follow-up. Then we did some phone surveys during COVID, and then the end-line survey there, late 2022, early 2023, I will refer to as the 3.5-year follow-up. And the study design is pretty straightforward. We had 332 villages enrolled. We grouped those into clusters of villages to minimize across-village spillovers. And those 121 clusters were randomized into a program group or intervention group, treatment group that received the Healthy Villages program, and a control group that did not receive anything. Randomization was done stratified on province. We worked across 4 provinces and the number of villages per cluster. You can see here, October, December 2019, that's the 5-month follow-up where we interviewed 4 households per village. And then January, February 2023, we interviewed 10 households per village, including the 4 that we had interviewed earlier. And there we were able to reach about 90% of the households we had interviewed before, which I found to be a remarkably low rate of attrition given the context. But the results that I show you are actually, we're not taking advantage of the fact that we're interviewing households twice, at least so far, but happy to hear ideas about how that might be valuable. So here are the 4 provinces where we worked, the ones that are colored in there: Kasai, Kasai Central, Congo Central, and South Kivu. Data collection in Congo is very challenging. My hat goes off to the survey firm IFRA that we work with. This is a look at the balance table at 5 months. These are household characteristics that we would not have expected to change in response to participating in the program. Things look fairly good here. The improved roof is where you see the largest difference, but household size is about 7 in both groups. And in both groups, about 65% of respondents have not completed primary school. The respondent was the head woman of the household if she was available. So now looking at a implementation fidelity. These are the 8 steps that I mentioned before, and we are really using step 6 as the indicator that the program was implemented. That's where the infrastructure is built, and that's coming after the behavior change campaigns and participatory analysis. So at 5 months post scheduled completion of the program, about 78% of villages in the treatment group had completed step 6, which we think is a reasonable rate of implementation completeness for a program operating at scale in a place like Congo. So at 5 months, we measured these 4 outcomes. Time to collect water and quantity of water collected showed no difference between treatment and control, whereas access to an improved water source was 33 percentage points higher in the treatment villages, and access to an improved sanitation facility was 26 percentage points higher in treated villages. So this gave us a sense that it was worth making the extra investment and measuring health outcomes at a later point, which turned out because of COVID to be 3.5 years after program completion. We measured a number of secondary outcomes at 5 months as well. Water governance is a function mostly of the presence of a committee, a WASH committee. People reported higher satisfaction with water in study villages and better sanitation practices and hand washing, but those are self-reported, and I have some, we tried to measure those more objectively at 3.5 years, which you'll see in a moment. So just to look at adherence or implementation fidelity at 3.5 years, there, step 6, we're up to 86% now. So a few slow villages did something after 5 months. Okay, so this is the headline result. Our 3 primary outcomes at 3.5 years were diarrhea, length for age, and this index of WASH institutions. So diarrhea is based on self-report by caregivers of children under 5, and we see no difference between intervention villages and control villages. Similarly, for length for age, that's in Z-scores. In terms of a Z-score, we see no difference between intervention villages and control villages. We do see a 0.37 standard deviation improvement in the WASH institutions index in treatment villages relative to control villages. And to dig into that a little bit more, this table, the top here has the same 3 primary outcomes. The bottom table gives you the individual components of the institutions index. And looking at the top, you can see that the prevalence of diarrhea in the past week is quite high in this context, about 40%. And the mean length for age Z-score is 2 standard deviations below the WHO recommendations. And looking at the institutions index components, this improvement is really driven by the presence of a committee, which is in 99% of treatment villages compared to 69% of control villages. And treatment committees or committees in treatment villages are also more likely to report that they track the health of the community. Turning to secondary outcomes, there's a lot going on here, so let's take a moment to go through. The first two are the same as two that we measured at 5 months. So we still see this persistent higher access to improved water sources and improved sanitation facilities at 3.5 years. The differences are not as great as at 5 months, but still substantial. And we also see that there is this governance perception index is a function. It's really about satisfaction with water governance, and respondents in treatment villages are reporting higher satisfaction. Water point working is lower in treatment villages, meaning we assessed each water point in each study village, and we interpret this as being a function of the fact that surface water and unprotected springs can't break. So if you're improving sources, it sort of opens you up to more problems with functionality. There are two more anthropometric outcomes following that: weight for age, weight for length, where we see no difference. And then we get to these two measures of hand washing, one self-reported, and the other is based on structured observations, where we asked a research assistant to spend 2 hours in a respondent's home, recording if hand washing was done after critical junctures like preparing a meal. And you can see there's quite a difference. They're not exactly on the same scale, but essentially when people were observed directly, there was no difference in the amount of hand washing between treatment villages and control villages. There's a slight increase in hand washing with soap compared to control villages, but that's not statistically significant. And then lastly, on the far right here, psychological well-being, life satisfaction, and self-esteem, we see no difference between treatment and control villages. So what is it that might explain this lack of health impact despite more access to improved wash facilities? Here we are thinking about 3 possible explanations. 1, water quality. 2, is it that people were simply not, when they're out at their fields cultivating crops, are they not able to use these improved sources? And 3, is it a story of water quantity? So we went to each water source in villages and measured the quality of the water using this test that gives results in one of 4 categories in terms of the number of thermotolerant coliforms per 100 milliliters of water. So that category on the right, where it's greater than 100 coliforms, is the very highest risk. And you can see that nearly 80% of water points in this study had that very high risk level, and there's very little difference between treatment village water points and control village water points. Looking at water quality by source, this helps explain why we don't see much of a difference between treatment villages and control villages. The 2 types of sources on the left, piped and public tap and protected spring, those would be considered improved water sources. And yet, even in those types of sources, we see 60 to 65% of water samples were in that very high risk category. So they're better than the unprotected springs and the surface water, but not much better. And since diarrheal disease is really, you really need to be eliminating the pathogens that you are consuming to prevent diarrheal disease. So this is not doing the job. And then, so given those 2 results, it's no surprise that when we took samples at the household level, we did not see a difference between water quality in treatment households and in control households. So the second explanation was about where people are spending their time. And this figure here shows on the left, what is the primary water source that people are using when they're at home? And you can see there is a significant difference between treatment and control households, and that's reflected in that 20 percentage point difference we saw in the secondary outcomes, where you can see treatment households are much more likely to report using a piped or public tap or a protected spring relative to control households when they're at home. But about 2/3 of our respondents reported that they spent at least one day a week at a field cultivating crops. And when they are at work or at their fields, people in both groups are quite likely to use surface water or to use unprotected springs. And again, those have the very lowest water quality. We did not ask about whether people are bringing children to these fields, so we don't know exactly what amount of exposure kids are getting through this channel. But one last fact here about working in fields: people who spent time in the fields, 94% reported defecating in the open rather than in a sanitation facility. Okay, and then the last possible channel had to do with quantity of water. We saw no difference in quantity of water between treatment and control, and this figure is showing that most of the households in this study population are not collecting the 15 liters per day that is kind of the recommended minimum by the WHO. So where does all of this leave us? This is a rather complicated program in a very challenging context, a conflict-affected context with poor infrastructure, and yet, you know, $7,000 per village. The median village size is about 450 people. So this is, I think that works out to $15 per person, if I remember the last time I did that back in the envelope. So this is not an expensive program, and it did successfully improve infrastructure and create these WASH committees that persisted for 3.5 years, but there was no benefit in terms of child diarrhea or child length for age. And that's probably due to this absence of a significant improvement in water quality, although quantity is another possible channel. So I thought I wanted to include this quote from Pickering, Luby, Arnold et al., who did this wonderful set of RCTs of WASH and feeding interventions. And they call for more research to identify interventions that radically reduce fecal contamination in the household environment. Because what they're seeing that is consistent with our findings here is that even after WASH interventions, and in their case, you know, household directed, quite intense WASH interventions, children's fingers have 10 times more indicator bacteria than British children. So these are the leading theory is that there's chronic environmental enteric dysfunction that is driving growth faltering in particular, and that it's going to take much more intense interventions to prevent that than what's typical in the developing world. So let me just thank. There are many people involved in this project: the Congolese Ministry of Health and Ministry of Education. The Brits funded both the program and this study. UNICEF was a crucial partner. We had a lot of support from the Development Impact Evaluation Group at the World Bank. And again, this survey firm, the Innovative Hub for Research in Africa, did excellent work in very challenging setting. So I will stop there, and very eager to hear your thoughts and try to answer any questions you may have.
Thanks so much, John. That's a really great summary of the work, and I'm sure others will probably collect their thoughts and offer questions in just a moment. It's funny for me to ask a question because I was part of the work, but maybe I'll ask a question which I think might just lead you to sort of reflect on some interesting issues that I know we discussed quite a bit. And maybe one of the things that I think about that really is notable is the fact that in a conflict environment and in a really, as you said, in many cases geographically hard to access settings, these these health outcomes didn't move, which is very disappointing, but the access indicators moved by quite a lot. And then we have this question about whether institutions improved, and that's always challenging to measure. And so maybe you could talk about some, challenges in measuring it, different thoughts, that the research team had about sort of how to get at whether these new committees, which have been set up and which persist, over multiple years, how can we think about measuring that function?
Yeah, that is a question that I hope you and I and the rest of our colleagues can spend some serious time on. I mean, so I guess we should start maybe with I think the theory of change that wasn't always explicit with this program is that you create this committee, and then the committee becomes responsible for not only maintenance, but maybe if the village has aspirations to continue improving its wash infrastructure or practices, the committee can be some kind of conduit for that. And that probably requires some sort of revenue generation. And what we, I guess what surprised me about looking at what these committees are doing is that very, very few, I think it was on the order of 5%, were collecting any revenue at all. And so, this might be just another case where we are expecting, we being the donor community, let's say, we are expecting people in very challenging circumstances to do even more than they're already doing. And that might not be realistic. Yeah, but, it'd be great to know more about sort of how these committees see their duties and roles and what their ambitions are going forward.
Thank you. I think there's a question from Ulla.
Yeah, thank you for a great presentation. It's really impressive and a well thought out design, I think. I know from similar studies, some groups have done kind of formative research, including medical anthropologists and other to identify kind of possible barriers to uptake of the intervention. This was, of course, a physical infrastructure project, but I just wondered whether you know if there had been some kind of formative research before the project started.
You mean formative research in terms of what is driving people's behaviors that are relevant to water and sanitation? Yeah. Our group, we had a qualitative process study that was undertaken sort of in the midst of between our 5-month follow-up and our 3.5-year follow-up. That, let's see, I think I don't know that there were really strong conclusions drawn in terms of, like, when I think about some of this formative work, it's exploring things like, should we emphasize disgust more as a channel to get people to avoid contamination? Or is it like, can shame be a useful tool in the community? Or do people just need to understand more what the benefits for their children's health are of this? And our process evaluation, I don't think went in any of those directions. And I don't know which of those sort of channels might be more important in this context. That's something I think there's actually a group at Hopkins that's looking into that in Congo, and maybe we can piggyback on their work. But again, I think, these sort of tweaks around individual behavior, I think, are just unlikely to create the sort of drastic reduction in exposure to pathogens that we need to move the needle on health.
Great. I think we have Aisha and then Elisa and then Chris.
Thanks, Kevin. Thanks for a great presentation. My question was actually the same as Ole's, but what I might just ask instead was, in the beginning, you shared that there was a behavior change component, right? Behavior change communication component. And I just wonder, like, who was that targeting? And again, sort of what insights do you have from the whole kind of process about how that might look differently going forward in future work?
Yeah. So, in my dream world with an unlimited budget, we would have parsed out each component of this program and done a factorial trial where we could isolate the behavior change component from the infrastructure and from the new institutions. We clearly didn't do that. So I can't really draw any firm conclusions about what the behavior change component did or didn't do. But I can tell you the intention of the behavior change component was to involve the entire village in these really participatory processes where there are group discussions about, why are our children getting sick with diarrhea? What can we do? Like, where are we going to the bathroom and how can we change that? How can we wash our hands more? Like, what are the barriers preventing better hygiene? And yeah, I think, according to the manual, and we didn't measure this unless I'm misremembering, Kevin. This should have been like a fairly intense 2 to 3 days early on in the process, and another 2 to 3 days, maybe a month or so later. So it is interesting. There's a recent review showing that contact in terms of promoting hand washing needs to be at least every 2 weeks, if not more often, to produce enough gains to improve health. And that may have happened for that brief, 1 to 3 month period, but by 3.5 years later, that's quite a long time in the past.
Yeah.
Great, Lisa.
Thank you, Kevin. Thank you, John. This is super interesting. I'm doing also some work on water, as Kevin knows. And I think you have an interesting pitch to me. I have a comment and a question. So the first is that I think a lot of policymakers, we're doing some work with the government of India and Nigeria, really focus on the first step, that is access to water. But I'm taking this evidence and making the point that what we really need is access to safe water. That is a very different issue, and sometimes come kind of second stage in the mind of the policymaker, but it seems an interesting, you're providing the evidence for it. And related to that, if the piece is really safe water access, I'm not sure about the water infrastructure in DRC, but in other contexts, it's quite heterogeneous. And so I wonder whether basically you have any evidence in terms of heterogeneous effect where you can say some of the water sources that are safer to start with, would you see any impact, I guess, on the health dimension there that you can kind of claim is really access to the safe water? So I was just curious about it.
Yeah, that's a great idea for next steps with this data set. We just a couple days ago had a look at correlations between water quality in the villages, I guess in the household's main water source. Actually, it's not totally clear how we did this, but we just had a quick look at water quality in terms of level of these thermotolerant coliforms in a village water source, and these diarrhea and length for age. And we didn't see anything based on this quick look. And I think a lot of the relevant, so much of the stunting happens from 0 to 2, so we might not have sort of enough children in that age group to do this kind of finer grained analysis. But because we have that data, we want to keep thinking about that. And yeah, I think that's a very promising way to go with this data set.
Thank you.
Yeah.
For you, Chris.
Great. Thank you, John, for your talk. I'm just trying to reconcile your findings with WASH benefits and then think about where to go next. So WASH benefits, they said, oh, we didn't do as much community-based because there's so many, exposure routes. And then yours is a little more community-based, maybe not as intense as some of the WASH benefits. So I'm trying to think, is next combining these, or where do we go with these two different types of trials to next in this area?
That's a great question. Yeah. So maybe just for people who might not be familiar with WASH benefits, so they provided chlorination of water at the household level, and I think they improved sanitation facilities in a similar way to here. And then they provided this high frequency sort of reminders and assistance with hand washing. They delivered soap and maybe even hand washing stations. So pretty intense household level, and they found no effect on length for age, on growth faltering. One of the possibilities, as you said, was that you need to reach a certain community threshold of these services. Targeting individual households might not be sufficient. So what we have here is something that in theory benefited the whole community, or at least, we're seeing these 15 to 30 percentage point increases in people with access to improved sources or facilities, but no chlorination. So the water quality here is probably much lower. So I guess one way to think about, and both our trial and their trials found no effect. So yeah, maybe if with a much larger intervention budget, if you can do something as intense as what Wash Benefits did for every household in the village, maybe that would lead to some results. But I know that the systematic reviews have not, at least on sanitation, have not found any relationship between sort of the community level of sanitation and the size of the benefits. So there is, I guess there's something mysterious going on, but what's not mysterious is that sort of none of these interventions seem to be doing anywhere near as much as we would like. I mean, even the targeted, the infant feeding that's part of this is, I think, reducing like an eighth of what they see as the gap between status quo in these places and where children should be on the growth chart. So again, it seems like much more intense interventions are needed.
Any further comments, questions? If there are no others, maybe I see a comment in the chat. Let me just briefly open. So it's from Cora Cunningham. Cora, do you want to answer the question yourself, or if not, I can read it?
Hi, sorry, I can't have my camera on, but sure. I'm wondering, well, first of all, John, thank you so much for your presentation. And I was wondering if you could elaborate a little bit more on like overall management and maintenance of sanitation facilities, because you talked about community participation. Was this something that was mostly overseen by community members? Was it the partners that you were working with? And like, if so, what did that waste management look like?
That's a good question. So most households in these villages, if I remember correctly, have their own latrine, pit latrine, and then the program is providing this concrete slab to improve the latrine, makes it slightly better to keep clean, at least on the surface. Now, are people emptying out this latrine periodically, or what are they doing when the latrine fills? I don't know that we have information on that, and I don't know what the norms are if the latrine is shared with other households in terms of who is responsible. My sense is that people tend to dig a new latrine when one fills up in rural areas, because there aren't many good options for processing the waste. Yeah, I don't know, Kevin, if you have other recollections of what we collected on this.
Not on that question specifically. I wondered, actually, this is slightly pivoting, but since I don't see other raised hands, maybe I'll ask a question which maybe is forward looking. And this is about kind of evidence translation going forward. I think one of the things that's interesting about this program, and this touches a little bit about on the questions about formative research, and I think one of the reasons probably why we weren't as involved in the formative research is that the RCT entered the picture when the program had already been running for almost 15 or 10 or 11 years. And so, one hopes there was quite a bit of formative research done, but it would have been done sort of in 2006, 2007. But then that also relates, I think, to the policy translation. I remember very well at the kickoff workshop, John, I bet you remember this too. One of the government officials said, well, it's nice you're doing an evaluation, but we know that this reduces diarrhea by 95%. So like, we love this program. It's a great program. Evaluation is great, but like, not really necessary. And we thought, okay, well, we're going to do the study anyway. Like, we hope it reduces diarrhea by 95%, but let's see. Then you have the other side, which was the funder, DFID, and they funded the evaluation, but then they decided to not continue the program even before the results were in. And so there were many ways in which the kind of potential uses for evaluation as a tool for decision making, didn't quite play out that way. Do you have any sort of reflections on going forward? How sort of the translation process for these trials could be improved, or even where this evidence is likely to fit in the kind of evolving WASH landscape?
Oh, that's such a good question. I wouldn't want to hold the policymaking process to too high of a standard, right? Like, we'll never be in a place where there's formative research done and then the policy and then the evaluation and then decisions to keep funding. But I think as our job is to keep synthesizing. I guess what's a little dispiriting about some of these studies that, well, you tell me if it's dispiriting or not, but I guess policymakers seem to really value evidence from their own context, or context as closely, as similar as possible. Whereas academics, we want to stress universal results. We want to publish universal findings. So, I think, I guess we can do a better job of trying to bring in evidence from other contexts and really trying to explain how it has value in different settings. Like, we might actually learn something from all of these Bangladesh trials that is applicable in Congo. The trials don't have to be done in Congo, but I would certainly like to see more done there. And I think there is a value to there's like the learning by doing that's not captured in our typical publications that is part of this process. So yeah, I don't know. That's not a direct answer to your question, but it is a messy and fascinating process.
No, I think it's a good point. I think there was an old paper by Pritchett and Sandifer, which showed basically that policymakers prefer poorly identified studies from their own setting to RCTs from other places, and that's not necessarily irrational given the size of the errors in both cases. We had a question in the chat, which I'm sorry that I missed a second ago, from Miles Kirby, and I'll read it out because it says he cannot go off mute. It says, is the program now considering household water treatment options, which has shown some benefits on diarrhea among children under 5 years?
I think the way the sector in general is going is looking at water treatment at the source, at the point of collection. Household water treatment usually requires a level of behavior change that's very difficult to maintain. Right. So if you're delivering chlorine packets to people's houses or something, it just, again, it's one more thing for people to do and who are already living in very challenging contexts. So something more like inline chlorination at the water source seems a lot more promising. And Michael Kramer and others have a meta-analysis showing that has benefits for child mortality. So I think that's kind of the direction that these interventions are going to go.
Okay, any additional comments or questions? Looking in the chat.
Kevin, I should have asked, what do you think about institutions going forward and how we think about them in this setting?
Oh, we had sort of developed plans to try to do behavioral measures, to see if we could actually measure how these committees were trying to solve local problems. And I think that would be something that we should try to do in future settings. So getting away from what committees say they want to do and trying to find naturalistic ways of observing what they do. Yeah, I think that would be exciting.
Yeah, I think at one point we had thought about could we raise money to give each WASH committee a grant of $1,000 and then observe, or give each village $1,000, and those with committees might use it differently than villages without committees or something like that. Yeah.
Well, seeing no further questions, and I'm sure John's happy to exchange, over email or in future. But please join me in thanking our guest today. And thanks again, John, for your great talk.
Thanks for the invitation. That was a lot of fun. Appreciate the questions and comments. Thank you.
Thanks, everyone.